Good evening, everybody. Sorry for the delay. There were some technical aspects. So we welcome you to this OPTAA webinar series. For those of you who do not know OPTAA, OPTAA stands for Occupational and Physiotherapy Alumni Association. The speaker and moderator may be wondering why I'm talking about OPTAA, because there may be some people who are outside the Alumni Association also who may be joining in. This is an association of people who finished BPT or BOT from CMC Vellore. And from March 2021, we've been having webinar series by alumni all over the world and from India. And we thank all the alumni who've taken the time in on a Saturday evening to take over sessions. So to introduce today's moderator, we have Ms. Margaret Christie, who finished a BPT from CMC, and she belongs to the batch of 2003. She's currently a private practitioner in Chennai. As you would have heard her speaking, she does private practice in people with geriatrics and women's health. And she's one of the advocates for women's health who's very passionate about women's health. Thank you, Margaret, for kindly consenting to do the moderation for today's session. And today's speaker is Ms. Anshul. Ms. Anshul belongs to the batch of 2002, and she's a registered physiotherapist, and she's a certified physiotherapist in lymphedema management and pelvic health, physiotherapy, oncology rehab, osteoporosis. I think she missed out a few more things for space requirements. I think she's a qualified professional. Thank you, Anshul, for taking your time and taking the class for us. And she's been a physiotherapist since 2008 in Owen Sound in Canada. And she's been a physiotherapist for the last 9 years. Thank you, Anshul. Anshul is married to Mr. Mahesh, who happens to be an alumni too. And they have family physiotherapy sessions. So thank you so much, Anshul, for consenting. There are a few ground rules for the webinar. We would request all of you to please mute your audios. You are free to keep your videos on. It may help you to interact with the speaker and the audience. If you are an alumni, we would request you to add your name with your badge. And if you are from other institutions, we are very happy to have you. Thank you for making your time in. And we would like you to have you with your institution name so it's easier to network and identify you. Please feel free to ask questions. If you are too shy, you can type in the questions as well. We would be happy if you could use the raise the hand function. And there may be some delays. So if you're speaking, please wait until the other person is completely speaking. We have ample time to answer all your questions. So please wait until everybody's, maybe we'll have time to answer all your questions. And due to some technical difficulties, we are not able to do the recording from here, but we are doing a screen recording, which should be made available in our YouTube channel. So thank you, Anshul and Margaret. Over to you, Margaret.
Okay, thank you. Thank you, Lenny, for that. Hello, Anshul. So I think we will start right away, and on the go, we will just get along, and if we have anything, we will, I think we will complete the session and then go in for the question answers or doubts, if any. That would be a better thing, right, Anshul?
Yeah, that's right. I mean, you can put your questions in chat. I will give a little break for answering questions if I finish kind of a block. But you can always put your questions in the chat. If I find that the answers need to be elaborate, put your email address and I will respond through an email as well. Like, if the answer is just too big or requires a lot of other background.
Yeah.
So I will do that
and
as well.
To the audience, like you can ask anything that is being presented. You have any doubts, or if you have any opinion or different things, different ideas or different ways of treatment, you can add on to the points that she makes. So it's just not like going to be a mere question answer session or anything. You can, it's going to be more of an interactive session. Yeah. So we'll wait for her to finish first though. And then, like she said, a block or something, and then we will go on with it. Over to you, Anshul.
All right. Well, thank you everyone who's joined. It is really encouraging to see so many people. My name is Anshul. As Lenny has already told, I'm a physio. I work in a private practice here in Canada, and my major caseload is women with urogynecological problems, which also includes things that are oncology related, because that really gels well. All the certifications I have is basically to supplement women's health and to be able to provide services which are a little bit more holistic and can provide better care to the patients. Okay. The presentation I have today is called Assessing Pelvic Health in Musculoskeletal Settings. The reason I decided for this presentation was because what I realized was that once I transited from musculoskeletal to women's health, there was so much of knowledge that needs to be transferred over back and forth. And a lot of time when we think of pelvic health, we think of pelvis, we just think, it's women's health. It's nothing that I have to do, especially when you're treating patients with low back pain and hip pain. But there is so much more overlap than what we see and what we have learned so far. So I wanted to knowledge share. This is really not a teaching session because I don't think I qualify as a teacher. This is more knowledge sharing, my experience and my knowledge from what I have done so far. Okay, so the reason we have this presentation today is that I would like, after this presentation, for therapists to be more pelvic aware while treating their clients when they have patients that have symptoms in their low back and hip, sometimes even above that, to find out if there is a component of pelvic health in the diagnosis. Just understanding simple and basic mechanics of pelvic floor because it is a part of musculoskeletal system, and also to screen and refer the patients when needed. So those are the objectives of this. What's the biggest difference between pelvic floor and other muscles of your body? The answer is there isn't any difference. They are just the same. A lot of time it's really good to compare your pelvic floor with your biceps because they are, they have exactly the same kind of characteristics. So this is a small video I have trying to get to that. Just give me 1 second. Yeah, here you go. So that's kind of a visual of your pelvic floor. So that's from the back. So see how close it is to your hip and your low back. So just with this anatomy, you can kind of realize how it is actually a muscle. It is the same soft tissue as your biceps. So treating it differently doesn't serve a lot of function. It does not serve our patients the best if we treat pelvic floor differently and we put it in a different box altogether. So just like any other muscle of your body, your pelvic floor is a group of voluntary muscles. It is contractile tissue. It has fast twitch fibers. It has slow twitch fibers. It fatigues just like if you work out too much, your biceps will fatigue. It needs to be worked and moved through its full range of contraction and relaxation. You know how you have the inner and middle and outer range for any other muscle. Even your pelvic floor has to have that range, and you need to move it throughout the range. And it needs to work in coordination with its synergist and antagonist. This is the same thing as you will think of any other muscle in your body. I don't have to name the pelvic floor muscles. Most often the ones that we work on as physios is your levator and all the components of your levator and so those are the bottom guys. And then on top of that, the other muscles that we still consider pelvic floor are your obturator internus and your piriformis. Those are two muscles that are in combination with your hip. So they are hip rotators, but they also are we call them the muscles of pelvic wall. They are also component of that pelvic inlet. They're also part of your pelvic floor. So all those muscles is what I'm talking about right now. So what do they do? What is the function? It supports your pelvic organ. We all know that. We all know that in women, the bladder and the uterus. In men, the bladder is supported by your pelvic floor. The sphincter function, your urinary sphincter and external anal sphincter, both of them have fibers. Both of them have involuntary fibers, but they have quite a bit of voluntary fibers from your pelvic floor, and it blends in. If you look at the anatomy, if you look at the transverse section, you'll find that how that there is a mix of voluntary and involuntary fibers within your sphincters, and the voluntary function of your pelvic floor supports your sphincters. Sexual functions in male erection and in male and female orgasm is mediated by how healthy your pelvic floor is. Stability. Your pelvic floor is a part of your core complex. This is something that we will highlight on in coming slides. And you'll understand how important pelvic floor is for core function. We will put those blocks together. The next function is sump pump. So this is a lesser talked about function. As a lymphedema therapist, this is something I see often. The pelvic floor being nice and strong and good contractile. You know how when you talk about a muscle, you always talk about how it is able to have good length as well as good strength, right? That's the characteristic of a good muscle, a healthy muscle, not just being able to be strong, also being able to lengthen. So that sump pump function allows all the lymphatics and the venous flow from your pelvis to go, it aids in the venous return, it aids in lymphatic return. Those who are women here and they have ever been pregnant, they will know how as the uterus gets heavier, they feel congestion around in their external genitals as well as their leg muscles. And the function of pelvic floor, when you work on that, then you can improve the venous and lymphatic. Okay, so we'll carry on.
Yeah.
So the next function and the next three things that we're talking about here, right? I moved too fast. The one function we always talk about is how your pelvic floor maintains continence, which is ability to keep yourself from wetting yourself or keep yourself from peeing, right? It forms a nice and firm backing over your urethra. So if you have your urethra, right, and then you have your bladder, and then you have your pelvic floor underneath that, when there is increased intra-abdominal pressure, that firm backing of your pelvic floor actually kinks your urethra and keeps you from leaking when you laugh, cough, jump, run. So that is a very basic and it's very well-known mechanism of pelvic floor keeping you continent. So oftentimes you'll see patients that may not have the best of the strength, but just because they have they are younger and they have a firm pelvic floor and their levator ani has not lost its thickness, they are able to be continent despite of their pelvic floor strength being 1 or 2 even. And you'll see that in postpartum women that sometimes they don't have enough strength on muscle testing for their levator ani, but they are not leaking when they are doing simple tasks like getting from the floor, picking their baby, or just coughing or laughing. But you will see that as they fatigue out their muscle, like if they cough, they have this bout of cough and they cough for quite some time, or if they keep laughing for some time, or they jump or they run, then they leak. That's because what happens is the demand is higher, and at that time, just a firm and thick levator ani isn't enough. You need it to be able to actually contract much stronger against the intra-abdominal pressure to keep your bladder from leaking. The next one is that your pelvic floor should be able to relax. This is something that when I started working in this field came to me, like, it was basically something really new. And this is what, 5-6 years back when I started this. It was really new to me because we don't ever think of that we need to relax our pelvic floor. A lot of pain disorders are related with a hypertonic or non-relaxing pelvic floor. I hope this is a news to some people at least. I don't want to state the obvious, but to be able to pee and poop, you need to relax your pelvic floor. A lot of time in our modern world, we do have clenched pelvic floor. We do have, and that could, in very simple words, end up having your muscles so tight for so long that you develop trigger points, tender points, tight muscles, all that happens to maybe even your trapezius, can happen to your levator ani, to your piriformis, to your obturator internus. And then you may end up having pain disorders of your pelvis. We'll talk about different pain disorders in coming slides. Now, the last one here on the slide is you should have coordinated contraction relaxation. Certain functions like being able to jump on trampoline or run, being able to avoid urge incontinence and urgency, and even sexual functions. You need your muscles to have proper timing. A lot of time you'll see the muscles are strong, but they don't contract on time. They don't react on time. And when they don't do that, then the patient is incontinent or leaks. And that happens a lot with athletes. It happens with people who are CrossFitters and all, and even weightlifters, that the timing is off. The strength is there, but the timing is off, and they end up being incontinent when they are loading, especially vertical loading. So that is all. Those are all the functions. Okay. Now, before this, if you have any questions, let me know. We can give you a five minutes to, not even five, yeah, 2-3 minutes, whatever, to ask if anybody has any questions in this section, right?
Okay.
How to
There's
work
someone
it.
who's got a question.
Yeah, go ahead. Yeah. What's the question?
Good evening. Good evening,
Yeah.
ma'am.
Hi.
Ma'am, I have about question of after delivery, how the pelvic floor will function. Like they might have done surgery, like episiotomy or LSCS. How the change? What are the changes will there in pelvic floor muscles?
It is totally like, there is no one word answer for that. It totally depends on your patient. Routine episiotomy is not recommended anymore. So tears heal more naturally. So we don't see a lot of episiotomy where I practice. Episiotomy is rare. But what happens to your pelvic floor during and after pregnancy is it's similar to what happens to you after any injury. Remember, the gravid uterus gets heavier, especially in the last 3 months, and the mother is walking around with a gravid uterus for 3 months. They most of the time do not exercise enough. They most of the time do not engage it enough. And after pregnancy, there is a good chance that you will see some amount of dysfunction. Most people, if they've been healthy, recover quite naturally. Most people, if they have been healthy prior, like, if they had poor core strength from before, then of course this will have more negative consequences later. But if they were somebody who were running or doing weights or doing exercises or yoga, whatever, then they will recover quite faster. There is not a lot of difference between C-sections and vaginal birth. There are complications during birth that could happen that would affect your pelvic floor. If episiotomy is quite large, stitches are too many, if the tear has gone further down into your external anal sphincter. So it's like a variety, right? So when you see your patient, you'll find out what exactly happened. How was their birth? How did they birth? When you know how they birth, you'll be able to know what dysfunction they could get, and then you treat them accordingly. So it's really what you're talking about it's a loaded question. We should have a full-on class on that. But there are a lot of changes, and if the patient was healthy and exercising before and during their pregnancy, the recovery is much smoother.
Oh, thank you.
Okay. All right. So the next thing is it's more to do with how we train our patients, how we connect with the pelvic floor. And this is not necessarily for a pelvic floor therapist. This is aimed for a musculoskeletal therapist. So the next slide here, it's a video. Let's see that, okay? So this is your core complex as we talk about. You can see it's your transverse abdominis that wraps around like a corset. You have your diaphragm on the top, and you have your pelvic floor on the bottom, and then you have your multifidus on your spine. So this is what we call the core complex. We will elaborate that. We call it the four of core. We call it the piston system. We call it the core canister. The transverse abdominis is like the walls of a cylinder. The pelvic floor and your diaphragm works more as a piston. So we talk a lot about core when we work out with our patients, when we teach our patients, let's do core stability exercises because you have chronic low back pain and so on and so forth. So core is not just having a stiff trunk, right? So the four of core, as we talk about, we have the transverse abdominis, like the walls of a cylinder or a canister. We have multifidus on the back. There's diaphragm on the top, and then there's pelvic floor on the bottom, okay? And when you take a deep breath, and we will talk about that a little bit later too, when you take a deep breath, the breathing mechanism, think of what happens. When you take a deep breath, the diaphragm from a dome flattens, right? And when it flattens, what actually happens to your pelvic floor is it lengthens and relaxes. And that's how the pelvic floor connects to your diaphragm. When you breathe out, after a regular inhalation, exhalation is passive. But if you continue to breathe out and do forceful exhalation, your transverse abdominis is supposed to come inwards. It's supposed to get engaged and get recruited, and your pelvic floor contracts. And that is how you recruit and engage your core. That is the forceful expiration or forceful exhalation is one of the best ways to engage your core. And in fact, if your patient is not able to do that, no matter how many exercises you give them, they are going to use compensatory strategies, and you will not be able to find them improving. And you'll be like, I'm doing core exercises with this patient, but their back pain isn't improving. That's because you're not able to engage their core, because you're not using all the components of core, because they are breath holding, or they are increasing their intra-abdominal pressure instead of decreasing it, right, to engage their core. So the core stability is the ability to control the position and the motion of the trunk over the pelvis to allow optimum production, transfer, and control of force and motion to the terminal segments in the integrated athletic activities. Now, not just athletic, it could be any activity, right? It could be getting up from the floor for some people who are really, really weak. Think of somebody who's really weak and has had a disease, and they are sitting on the floor. Think of how they get up. They often use their intra-abdominal pressure to get up, right? Eventually, now this person is quite weak. So when they get up, they go like grunt, they go like, right? If that strategy continues on, even though they have recovered from their disease, the motor pathways have learned this compensatory strategy, and they forget all about the actual breath to use to get that you and I will use to get off the bed or off the floor. So correcting it in that stage, that level, telling them blow as you go, or telling them, okay, breathe out as you move. From there, you can start building up the actual strength of their core. When your core is strong, when your core is nice and flexible and strong and is able to have that piston action along with the breath, you can use that force and have it transmitted to your extremities, your arms and your legs, and then the injuries are much lesser. So you get somebody who comes up with a shoulder problem, and then you ask them, okay, can you sit on the floor and get up? And you see they're grunting to get up. They're possibly overusing their shoulder muscles for the work that they're doing, whether that be lifting or pushing or pulling, because they're not using that big strength that we have inherently in our core. So they're not using the most optimal strategy for load transfer. So what you do is they come for the shoulder, but you tell them, we have to make sure that you breathe properly throughout your movement. So you're not grunting and you're not bearing down, you're not breath holding while you're doing loading activity, whether that be for your arm, whether that be for your legs. So as I write down right here, it's a mobile and a functional unit. It's a piston It's an effort generator that moves and changes as you move. And the basic movement behind your core is your breath. It sounds so simple. It sounds so much like, what, really? Just breathing? But breathing actually improves your core strength. I will show you a video of how your breathing connects with your pelvic floor. And pelvic floor, when I say pelvic floor, it is a part of your core, right? Okay. Now, diaphragmatic breathing is the most fundamental demonstration of core function. The breathing patterns that are optimal, they have an optimal diaphragmatic control. They are integral to the generation of core stability. And this breathing also affects your pelvic floor. If somebody is not breathing deep enough, if the diaphragm is not lowering and flattening enough, if they are more used to using their accessory muscles for respiration, these patients, their pelvic floor will not be able to get used or engaged enough for them to do actual load transfer activities. Their strategies will be less than optimal, and they'll end up having more injuries and more dysfunctions. Now I'm going to show you a video. Okay. Now this is a video. This is from Instagram. You can see the credit down in the bottom. I think it's Think Beyond Pain. This is an ultrasound. This is a transabdominal ultrasound done over the bladder. There'll be two different kind of breathing patterns you'll see: chest breathing and belly breathing. Now, that's a very simple way of putting. Chest breathing is when you use your accessory muscles of respiration. You're doing more shallow breathing. Belly breathing is when you do your actual pump handle and bucket handle mechanism. You know, pump handle of your sternum and then bucket handle of your ribs. Your belly rises, relaxes, the deep diaphragmatic breathing. So that's the second part you'll see. So let's see what happens here, okay? So if you see, your pelvic floor still moves, okay? Each time you do your chest breathing, when you're breathing, sitting where you're sitting right now, you're breathing, your pelvic floor does have some amount of movement. And you'll see what happens when you do belly breathing or a proper deep diaphragmatic breathing. You see how much more your pelvic floor moves. So this is how you engage, or you so what this tells us is that your pelvic floor is a part and parcel of your core and your breathing, because your diaphragm is a part of your core, your pelvic floor is a part of your core. If you don't engage them well, you don't have them work together, you're not going to have a good enough core strength. And then we can keep doing all our dead bugs, all our planks, and all of those exercises. We are not going to get anywhere. We probably are using all the non-optimal strategies. We are using all the muscles that are not supposed to be used, and we are not bringing the best out of our patients. So that deep breathing is something that you have to start with, especially with people who are older, right? Not just that, even sometimes you'll see athletes. The one thing that I see in runners is people just say, get up, and they start running, right? They're like, one fine day they wake up and they're like, I want to start running. I want to be a runner. You should see how they're running. What is their strategy? A lot of time when they're running, they're not breathing deep. They're not coordinating their breath with their impact. And then they end up having injuries. They end up having knee pain or back pain or hip pain, and happens a lot even to people who go to gym all of a sudden. You know, they'll get up one day and say, oh, you know what, I need to work out. You will hear so many people say, you know, my doctor told me to go to the gym and exercise. I went to the gym, I got back pain. I started walking on treadmill, I got back pain. A lot of time they have lost their basic strategy to breathe, and they, for the extra load that they're putting on their body by walking too much or running too much, they are overwhelming the system. So while they were not running and they were just sitting on their desk and typing on their computers, they were able to manage okay because they didn't need that extra help. But as soon as they go to the gym and they start working out, they need more core engagement. So when you see somebody like that, you have to find out how are they moving? How are they breathing? Ask them to lift a weight and see what they do. Are they grunting, or are they breath holding, or are they bearing down while they're, and that is the component I wish we use a lot more than trying to palpate the muscle. right? You should palpate the muscle and find out if it's firing, but that's not enough. You need to be able to observe their strategy. When you, for example, the people who work in the clinic, and you are, sorry, got interrupted. So when you, people who are in private practice or work in a hospital, they're calling their patients from the waiting room to their room to see them. I would want you to see what happens when they get up from the chair. Are they going like, right? Or are they able to get up without their hand support? When you bring them in your room, when you bring them in your examination room, you ask them to sit on the floor and see what happens when they get up from the floor. Are they grunting? If it's a mom that you're treating, ask them to bring their baby and see what happens when they pick the baby from the table. Are they breath holding, right? So where you see them in their natural environment, you see them in their day-to-day activities, and find out where what's lost. You know, if they have lost that ability, they are using that breath holding and grunting strategy to just put their socks on, and you try and make them do dead bug, they are not going to be able to transfer that. You have to, so what I tell my patients is, if I find them breath holding or bearing down while their day-to-day activities, I tell them to repeat the activities, you know. So this lady comes in and she sits on the chair, and I say, okay, can you get up and sit on the floor? So she'll sit on the floor. Then I'll say, okay, can you get up from the floor? And then she goes like, and all that, like, you know, she breath holds and she bears down, she gets up. And then she said, you know, I was not like that. I was not like that before. So I say, okay, let us get her from the chair one more time. So she gets up from the chair and she realizes she's breath holding when she's getting up from the chair. And I said, is that difficult? Is it that difficult for you to get up from the chair that you have to hold your breath? She's like, no, it is not. So I tell her to repeat the movement, this time with taking a deep breath first, and as she's getting up from the chair, to breathe out. And I tell her that each time you catch yourself breath holding, repeat the movement, whether that be putting your sock on, whether that be lifting a bag of flour or bag of rice from the floor, whether that be picking up your baby, whether that be getting from the floor. If you find yourself breath holding, do the blow as you go, like take a deep breath first, and as you are loading yourself, breathe out. Do that strategy, repeat it till that becomes a habit. Because even though you say, I have really strong muscles, if you have lost the motor pattern of coordinating your breath with your loading, you're not going to be able to transfer that skill to your exercises. And you probably, as soon as you fatigue a little bit, you're going to start using breath holding for all your exercises, whether that be running, jumping, you know, weightlifting in the gym. So if you're not doing that strategy in your day-to-day life, it's hard for you to do it when you're actually loading yourself. So that is the big connection between breathing and core and pelvic floor is with that. And I will talk about, I will talk about how pelvic floor disorders connect to this in my coming up slides, okay? So a lot of pelvic floor issues, they are, solved with when somebody comes to you and says, you know, I'm leaking when I go to the washroom, before I reach the washroom, I'm leaking. Okay, you do your Kegels, is what most people tell them, you know, and internet tells them, and their doctors tell them, their girlfriends tell them, their mothers and their aunties tell them, just do your Kegels. But that's really not the solution, right? Now I do internal assessment, that I'm rostered for internal assessment, but you don't have to a lot of time. Just by getting an idea of what their problem is, you can kind of find out what part of the spectrum they lie on, and you can give them management according to that. So there are different kind of pelvic floor disorders. I'm going to talk about a few of them, and I'm going to talk about what goes wrong. And this is I think the most justified way is to never treat your patient as one single word diagnosis. Oh, he has stress incontinence, or she has urge incontinence. As physiotherapists, we should analyze the entire situation. Our diagnosis should not be one word. You know, I can't say, when you say, oh, this person has DRA, I'll say it's a symptom. It's really not the dysfunction. And a dysfunction cannot be described in one word. So one word diagnosis do not do good for functional therapists like us, right? We are functional therapists. We are not surgeons. We are not physicians that prescribe medication that works with one word diagnosis. Our diagnosis has to be an analysis of the entire situation. So the disorders that I'm going to talk about are mostly a symptom, and you have to actually find out what happens underneath that disorder and treat it accordingly. Okay, so we'll start with stress incontinence. Okay, stress incontinence, as we spoke about in the beginning. I hope I'm not going too fast. Do you think I'm going too fast?
Oh,
No, it's
no, actually good.
Okay, all right. So okay, coming back. So stress incontinence is when you pee when you are strained, right? When your intra-abdominal pressure increases and your levator ani strength isn't strong enough to keep your bladder continent, and that pressure from the top makes you leak. That is stress incontinence. If a person has pure stress incontinence, they come and say, I can hold my pee for hours together, but the moment somebody makes me laugh, I am leaking. The spectrum of stress incontinence can go from leaking when I run, leaking when I lift, 25 pounds, to leaking when I'm lifting my baby, or leaking when I am getting up from the floor, or leaking when I'm getting up from the chair. So that is the spectrum. Some people are just so weak that getting up from the chair will make them leak, because they're using their intra-abdominal pressure as a strategy to get up from a chair, right? And we talked about how in core recruitment, that's not the most optimal strategy. So we giving Kegels to them isn't going to be enough, right? Telling them to do Kegels isn't going to be enough. You have to work on their strategy, making sure that when they get up from the chair and they're leaking, that they're not breath holding or bearing down, and you add Kegels to that. So as I said, Kegels is not the solution for all the problems. If you don't do that part and you just teach them Kegels, I don't think that they're going to improve. And then you'll be like, it doesn't work. And then eventually they're going to go to the surgeon, and the surgeon's going to put a sling to support their urethra. And then they're going to continue on doing that bearing down strategy. And the urethral sling is going to keep getting pushed down. And then they're going to have the transvaginal tape rip off, and then they'll end up having more pelvic pain, because now, before they only had the pelvic floor weakness, now they have pain because they have injury to their pelvic floor, because they're hypersensitized, because the surgery has failed. 50% of bladder lifts and transvaginal tapes fail eventually because the mechanism because of which this problem had happened was not corrected, right? You have to correct the reason why they had to go through the surgery first. If they're continuing to do that wrong way of loading, their surgery is going to fail. That's why I say 50% is at least what is reported. There are probably more, but women are like, I tried the surgery, it didn't work, I'm not going to talk about it. So stress incontinence is not just, Kegels is one of the solutions, but it's not the only solution. When you see a patient with stress incontinence, find out what their core does when they load bear. Okay. And if you find that their core doesn't engage properly, they are breath holding, correct that first before you go to stress incontinence. The second one here is urgency or urge incontinence. Now, urge incontinence is different from stress incontinence, because urge incontinence is when you leak on the way to the washroom. You're like, I need to go. That is urgency. And when that urgency leads to dribbling or leaking is when we call it urge incontinence. Oftentimes, people with urge incontinence is what we call non-relaxing pelvic floor. Now, urge incontinence, urgency or urge incontinence, it can be a lot more complex than stress incontinence. So the assessment definitely is a lot more elaborate. But to simplify it, I'll talk about two factors that could be contributed to urge incontinence. The first factor is habit, right? This person, they started having, they started feeling like, I might leak. So they started emptying their bladder much before their bladder has reaching their capacity. So hence forming a habit or making their neural pathways make them feel like they need to go earlier than they actually need to go. So it's more to do with habit formation, that when you have the urge, you're just giving into the urge, right? So that habit formation, that I need to go every hour, I need to go each time I see a washroom, I need to go just because I'm leaving the house and I have to go on a road trip, I need to go when I turn the tap on, I need to go as soon as I come to the house and I put my key in to open the door to get inside. So that is more habit, that's more mind over matter. They should, so what we do is we teach them urge delay strategies. We teach them how to distract themselves and keep the urge down and then go to the washroom. So if somebody comes like that and they say, you know, I don't leak, but the urgency is just too much. So I tell them, okay, this is what you do. When you get the urge, stop. Don't rush to the washroom. Take deep breath. Do some of your levator ani contraction, relaxation, which we teach them in the clinic, contractions and relaxations. Count backwards, you know, balance your checkbook, do something to distract yourself. And once that sharp urgency, it subsides, slowly walk towards the washroom and sit down. So what you're doing is you are, in very, very simple words, you're not giving into the tantrums of your bladder. You're waiting for the bladder tantrums to subside, and then you're still listening to your body. And oftentimes you'll find that that urge itself stops coming so quickly that you allow your bladder to fill in more and more. So that's one of the factors, okay? The second factor, which is not as much talked about in literature, and I know that eventually we will see more of that, is inability of your pelvic floor to relax, right? So your detrusor needs space for your detrusor, your bladder needs space to expand. If you have a pelvic floor which is congested, non-relaxing, tight, you will find that your bladder gets the signal of fullness prior to its actual normal physiological capacity, right? So people with non-relaxing pelvic floor may also have urgency. And for them, just habit change may not work. So you teach them how to relax their pelvic floor. And as we saw in that video with the ultrasound before, the way to relax your pelvic floor is by engaging that deep diaphragmatic breath, allowing your diaphragm to descend and allowing your pelvic floor to expand. What I tell my patients for that is I give them some stretch postures like child's pose or happy baby pose. And I ask them that at the end of their stretch, like, you know, they go to the posture, as they maintain the posture at the end range, take deep breaths into their pelvic floor. I use cues like, breathe into your tailbone. I use cues like, do opposite of what you do when you have to keep a fart in. Now in pelvic health, you use all these, you know, pooping, farting and all is common words, right? So you can't be shy about that. So I tell them, okay, unclench your butt. Let the air come all the way to the bottom of your pelvic floor. And a lot of time that itself works really well for people who have non-relaxing pelvic floor. Some people need a little bit more work, more tissue work. So you do internal release and all that. That is a very different skill set. And we can talk about it if we ever have a chance to do more of those kind of classes, okay? So that is how we deal with urge incontinence. Now is that okay? Is there anybody who needs to ask a question, or am I going too fast?
Yeah. The first one you said, right? The first factor, the habitual thing, the retraining thing. Do we apply the same strategy with people with head injury when they have frontal involvement?
I don't think, because that's a neurological issue, and that has nothing to do with voluntary work, right? So I'm not qualified to comment on a neurological bladder.
Okay.
And I think Manju has something to say. Maybe because she is a neurophysio, she may be able to give us an answer. Is that right, Manju?
Sorry, Anshul, I had a question. not an answer.
Sorry
about
sorry
that.
So coming back
Okay.
to Margaret, if you have an upper motor neuron lesion and you're having bladder issues with that, that is way beyond the scope of what I practice. I will send them to a physiotherapist. We have one in town here who has training in neurology as well as pelvic floor. So I will not want to invade in that territory.
Okay. Okay. That's good. Manju, you can go on with your question.
Anshul, just wanted to know, like when we mothers train the kids for toilet training, does the timed voiding and things like that, does those techniques have any effect on, later on stages and developing urged incontinence or stress incontinence?
So Manju, this is definitely an area which is developing, right? We are, when you are toilet training them, you are training their bladder, but you're training their bladder to fill to its maximum before they void, right? You're not asking them to go every hour, right? So there are right and wrong ways to bladder train a toddler. There are right and wrong ways. You know how in the olden times in India, we did not have diapers and we were free to go, right? And then we developed a conscience that, oh, we are not supposed to wet ourselves in public. That natural way, in my opinion, was the best way, right? Where the child learns on their own. And if you remember, a lot of kids were toilet trained by 2 years. Now, this using a diaper, it's much more convenient for us people, mothers, than it is for the children, right? Using diapers, it doesn't give them the feedback. It doesn't, and now the diapers keep them dry, so they don't even know what's happening, right? So they are not learning intuitively. And that's why now in the modern world that we use diapers and all that, we end up having to toilet train and time void. That's a newer concept. That's not how our bladders were intended to train. Our bladders were intended to train from childhood on to respond to the inconvenience of it, right? So it's time void, it's convenient, but would it lead to issues? It may, if that habit is not broken, if the children not allowed to be more intuitive about their bladder habits, right? So it's a fine balance. If you're a working mother, you're not going to be able to keep them off diapers and have them pee whenever they want and have them pee and realize they are wet. It's hard. It's hard. And I don't want to put a pressure on a working mother saying, oh, you shouldn't use the diaper. but honest answer is that diapers don't help a lot. That's the honest answer. And I wish it wasn't like that, but it is what it is. So having children go to the toilet before you leave home is definitely not a good thing. You know, if they're not feeling it, you don't want to train them and say, go just because, right? Now in India, unfortunately, it's very hard because you don't find toilets conveniently. In more developed countries, you'll find that we have toilets easily available. But in India, that's a hard thing, right? So a lot of mothers resort to that when they're going for a long bus ride or a road trip. They resort to that. I don't think that's the best. I wish it was better.
Yeah. Thank you, Anshul. Thank you.
Okay. All right. So the next one is mixed incontinence. Now, mixed incontinence, I'm going to give you all an example. You know, this mother, she birthed the baby and she was pregnant for the 9-10 months, and then she birthed the baby. She had a tear, maybe even just a first-degree tear. She was breastfeeding, so she developed some dryness and she had dyspareunia. And she started having leaking, right? So what did she do? She started clenching and she started doing Kegels, right? And her pelvic floor, because of the pain, because of the tearing, because of over clenching and doing just Kegels and holding it too much, became that non-relaxing pelvic floor. So now she comes to you and says, you know, I leak when I laugh, but I also can't hold it till I go to the washroom. and this person will then have mixed incontinence. Just think of any other muscle that comes to you with pain and tightness. You're not going to start strengthening it right away. You'll first try to bring about the optimal length to that muscle, and then you're going to start training it for tightness. So what I tell these patients is, and as I said, these are just very, very, very fluid examples. People are much more complex than plain fluid examples. I would tell them, let's start with relaxing it first. And I tell them that you probably will take some time before you can be continent against intra-abdominal pressure, or continent while you're coughing or laughing. But first, we need to kind of restore the normal length of your pelvic floor. So I start with relaxing first, lengthening first, stretching first. And then once they're able to hold their urgency a little better, I move on to strength. And oftentimes, if you do not coordinate your transverse abdominis with your pelvic floor, you don't get the best response in terms of improving your levator ani strength, because they're wired together, they fire together, they are together. They just, because of our convenience, we talk about how transverse abdominis originates from here, inserts here in pelvic floor, like your levator ani originates from here and ends up here. In true anatomical sense, it's one fascia, right? And because it's wired together, it will fire together. And there are experts that talk about pelvic floor being the driver of your core, right? So if you're not going to work both these guys together in coordination, you may not get the best results. You will not be able to reach the best of the potential for that patient of yours. So that is your mixed incontinence. Again, as we talked about, working with diaphragm, transverse abdominis, and pelvic floor, even here we're going to use the same strategy. Now, pain. Now I'm gonna give a little break. I hope we're not running out of time. I don't have any way of keeping time. So yeah, I'll give you guys a little time to ask questions if you have so far, and then we'll go to pain disorders.
Okay, there was one question that was asked. What are the symptoms of a hypertonic pelvic floor?
What are the symptoms of an hypertonic pelvic floor? Urgency is like, and because I am an internal therapist, for me, the assessment gives me the answer 99% of the time. But if somebody comes to me and tells me their complaints and history, and they have pain, they have back pain or hip pain, they have urgency, they have dyspareunia, all those are often related with a hypertonic or non-relaxing pelvic floor. So if you are not an internal therapist, you can assume almost 80 to 90% of times that these problems could be related with a hypertonic pelvic floor. In any case, teaching them to relax their pelvic floor is not going to harm them. So if you find that the symptoms are of hypertonic pelvic floor, go ahead and teach them how to relax their pelvic floor. That's going to be safe. Even if they don't have a very hypertonic pelvic floor, if you teach them to relax and take a deep breath, it's not going to harm them. So it's safe.
Okay. And do we have proper scales or rating to assess the non-relaxing pelvic floor or to assess urge incontinence?
Okay, so researchers use for levator ani strength, they use those tools, where you can use pressure, but that's more researchers. In a clinic setting, it's extremely difficult. The one thing which is most difficult will be sanitizing.
That's right.
Right? Because these instruments, you'll have to sanitize between patients and all that. For non-relaxing pelvic floor, it has extremely poor indurator reliability, because you don't know what is non-relaxing for you versus what's non-relaxing for me. We do not have any evidence that tells us how much non-relaxing it is. It just justifies the means, in the sense that what you're doing, it's not harmful. If they feel better, you're in the right direction.
All right. So it's very subjective, and
it is subjective. It is subjective.
Okay.
Yes, it is subjective. Yeah.
All right. We can go on.
Okay. All right. So pain disorders are something that we see the most in clinical settings, and almost all musculoskeletal therapists work with pain disorders. Pelvic pain of any sort, pain with sitting, dyspareunia, which is painful intercourse, interstitial cystitis is also a pain disorder, or bladder pain syndrome. Now, interstitial cystitis and bladder pain syndrome are way more complex. I don't think we'll be able to explain that in this presentation. Vaginismus, again, it's a pain disorder. Vulvodynia, vestibulodynia, all these are depending on where in your genitals and pelvic floor the pain is. That's classified according to where anatomically your pain is located. Sacroiliac joint pain, which is so common, like, we see it so commonly in musculoskeletal settings. It can have associations with your pelvic floor. Low back pain. There was a study done, I believe 2013 or something, where they found that, so what they did was, it was a multi-center study. It was done in Canada. One of the chief researcher for this study was Carolyn Van Dyken. She was one of our teachers. They did a multi-center study where they took women with low back pain, and then they did an internal assessment. And if I'm not wrong, 80% of women with low back pain had a non-relaxing or hypertonic pelvic floor. So that was, now it is it causation or is it correlation? We're still learning about it. But is it the back pain that causes the pelvic floor to get tight, or is the tightness in pelvic floor causing back pain? Is it because of a very tight and non-relaxing pelvic floor that they're not able to engage their core properly, and that is causing more stress on their spine? Probably. We do not still have answers for that. Remember, this was a 2013 studies. They are following up. Hopefully we will know more about it in more clarity eventually. Working with this hypothesis that they are not able to work on their core and they are stressing their spine, they're developing tender points within their pelvic floor muscles. It works really well clinically. We get really good results with patients if we go that route. So I'll take it as truth, but eventually we will know if evidence supports it or not. Okay, now pain during pregnancy, right? All the different kind of pelvic girdle pain, whether that be pubic symphysis, whether that be sacroiliac joint, all that is also a part of your pelvic floor issues. When they are pregnant, we do not worry too much. When they're pregnant with pelvic girdle pain, we do symptomatic treatment, because we will not be able to know the full extent of the problem while they're pregnant. When they birth, 8 weeks, 10 weeks after the birth, you reevaluate them. If they are feeling better, nothing to worry really. But if they still are in pain, you start your investigation, like, you start becoming Sherlock Holmes and finding out what was the driver, what caused them the pain, and so on and so forth. And then you work on the interventions based on that. Okay, what interventions? Okay, yeah, DRA. A lot of people talk about DRA. I got a lot of questions from a lot of people about DRA. Very simple. DRA is separation of your right and left rectus. This may come to you guys as a surprise. 100% of the women by 35 weeks of pregnancy, they have DRA. All of us, when we are pregnant, we'll get a separation. That's how we accommodate a growing uterus, right? You have your rectus, then you have the linea alba, right? Your linea alba, which is nice and thick while you're not pregnant, becomes thinner and separates to accommodate your growing belly. It may also happen to you if you put on a lot of belly fat, right? Beer belly, right? You may get that separation. Now, in 6 months postpartum, 40% of women will still have separation. Most people do recover within the first year. We treat people who are not recovering well, who continue to have back pain, If somebody comes in with DRA and they are just 3 months postpartum, I will find out if they have other symptoms, if they are having core weakness, they are leaking, they have back pain, and so on and so forth. We'll treat that. DRA, we will not treat the traditional way anymore. We treat it very differently. Most people recover within a year. Some people have a little bit of aesthetic deformity, but functionally, as long as they're okay and they don't mind it, we don't mind it either. If they have more than 4 finger separation, and there is a measurement to it now, I can't remember, but if they have quite a bit of separation and a lot of symptoms, if they have doming on a curl up task, we refer them to surgery, right? If they have a big gap and we know, and they're not able to load their linea alba, we will refer them to surgery, just so that, and that's very, very minor population. In last so many years, I might have seen one person with that kind of a separation. She chose not to go for surgery because she was not having any symptoms. She said, you know, I don't care how I look and I'm quite okay. And she did not have any issues. She didn't have back pain. She was able to recruit her core okay. So we didn't bother about that. And we just discussed that in case things get worse, that was our next plan. So DRA, we don't treat traditionally. There is a researcher and a clinician called Diane Lee. She works from BC, Vancouver, BC. She has a wonderful website called learnwithdianelee.com. And she has paid content, but she also has an hour of free content about DRA. She does a lot of work with DRA. So what she did was, one of the studies she did was, you know how in the past we used to train DRA by, you know, bracing our rectus together and doing curl-ups in order to improve the strength of our rectus, right? Her study showed that because the studies done before her, they showed that engaging your transverse abdominis was not closing that gap, or, you know, they were not closing that gap. In fact, it was increasing the gap. That was shown in the previous studies, right? So that's why we were told, do not do core exercises like planks and all with DRA. That was told to us. Remember when we were in school long back, we were told all that. But when she did the study, I think because she saw a pattern, she did the study. What she did was she did an ultrasound investigation of your linea alba with curl up task and transverse recruitment, 2 different, right? And what she found was that when you do rectus strengthening the traditional way, your gap does reduce, but your linea alba distorts. Now, linea alba is a fascial sequence, right? It's a fascial structure. It distorts, and when it distorts, it cannot load bear properly. And she said, when you do transverse recruitment, which was against the traditional advice, the linea alba, it flattens, but it load bears much better. There is more separation when you see it on the ultrasound, but what she concluded was that's better way to train towards function than the previous traditional way. And that study, I'm sure, is available freely. I have a list of references for what I'm talking about today. And if anybody wants it, just send me an email. I will email you the list of references for what I'm talking, like what basis I'm talking with. But Diane Lee is, sorry?
Yeah, sorry. Can you just say the thing, the learn with her spelling?
Learnwithdianelee.com is the website. She has written a book called, I think it's called the Pelvic Girdle. And she has a few different, like there are 3 editions. I think sorry, yeah, you're right. Lenny is right. So she has a few editions. It's a very, very good book. Worth getting to is one of the books that is worth coming to a PT library. Great reference book.
Okay.
Anyway, so that is the new and different model of treating DRA. I would, as I said before, DRA will be a symptom. I will not treat it as a diagnosis. I'll find out what else is happening. What's the problem? Are they not able to engage their core properly? Do they use intra-abdominal pressure? Are they pushing out too much? All of that. And I'll work with that instead of just thinking DRA, 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 right? Because as physios, as I said, our diagnosis shouldn't be one word. We have to have like a full analysis of the patient with regards to their functions and their dysfunctions. Okay. Pelvic organ prolapse. It happens, we always think it happens in older women. It happens in younger women as well. Pelvic organ prolapse, I visualize it as a hernia. When men have that problem, they will get inguinal or umbilical hernia. If women have that problem, they end up having a prolapse. Now, I'm sure that your parents or somebody would have told you, don't lift like that or you'll end up having a hernia, right? For women, we often think pelvic organ prolapse is more to do with weak pelvic floor. Okay, it doesn't support anymore, so it, pushes down. But there is a good amount of evidence that talks about how grunting and pushing down, especially people who have constipation, may cause pelvic organ prolapse. So that's a very overlooked mechanism. And when you have somebody with prolapse, you treat them just with Kegels, it's not going to help them because they are going to continue to bear down, push down all of their pelvic organs when they're sitting in the toilet, and they have constipation. When they're lifting a heavy weight, they're going to continue to push down, right? And when they continue to push down, no matter how strong their pelvic floor is, if they're a woman, they will have what we call a levator hiatus, which is opening in their pelvic floor, and they have space for their pelvic organs to slide out, right? So working with the pressure distribution, helping them to blow as you go, breathing strategy will help them. Not a lot of evidence, but a lot of clinicians use this particular technique called hypopressives. Now, you know how increased intra-abdominal pressure will cause the pelvic organs to herniate or prolapse. Think of what happens if there's a decreased intra-abdominal pressure. The hypothesis is a decreased intra-abdominal pressure. The negative pressure in your intra-abdominal area may be able to get your pelvic organs sucked up, right? So that hypopressive techniques that they talk about, where you do force exhalation while drawing in your navel, the draw-in maneuver may help. As I said before, hypopressives is very new concept. We don't have mound load of evidence for that. There are clinicians that swear by it. There are people who do not understand the mechanism, hence won't use this. Your clinical discretion, as long as you're not causing a wrong pattern in your patient, as long as you're not encouraging a breath hold strategy, as long as you're not having them recruit their obliquus instead of transverse abdominis. Your internal and external obliquus oftentimes take over and they don't allow your transverse. Like you'll have a patient, you'll try a patient to work on their transverse and you'll find them, they are hunched over at their ribs, and you'll find that their internal and external obliques are really clenching and tight. As long as you're not doing that, as long as the TRA is very, very isolated, you are safe to do a hypopressive technique. I don't do hypopressives as such. I do not cause apnea and cause hypopressive, but I do teach patients drawing in maneuver and forceful exhalation, but I do not give them holds. I need to see more evidence before I start doing that. Yes, Margaret?
No, I was just about to ask something. About a patient. She has a combination of all this. She is an arthritic patient, she is an autoimmune patient. So she at times has a lot of pain, in generalized pelvic pain, and she has constipation, and obviously she has poor core. She's still not learned the art of relaxing. So her constipation, she's not able to relax. So her constipation still remains the same. And no matter how much you train the the other breathing component, and including, like, I tell her to suck in towards the navel and ask her to keep talking so that she doesn't hold her breath and stuff. Her constipation thing has not really, the relaxing thing hasn't really worked out. So is there any other strategy where we can target more at relaxing this thing, because that seems to be the key issue for her?
She's not able to relax. So I would, now this sounds more complex. The one thing is, she may have more than what eyes can see, right? She may have IBS. She may have other central issues. She may have anxiety disorder, right? Which keeps her from relaxing. If you are anxious, you won't be able to relax. So when you treat a patient with symptoms which are all over the map, what you do is what you can try doing is start with what you think was the initial problem. If you find that the problem started with her becoming anxious first, or if it was a food allergy that caused her to have problems with her bowels first. Imagine somebody with IBS who has to go, and then they end up taking medications to try from not going, and then they end up having constipation because they haven't addressed their diet, but using medications for that. So it's more complex than that. Or if they are put into situations where they get more anxious, whether that be financial, whether that be related to children, spouse, or anything. You have to find out what's the driver behind their problem, address that, and then go back from there. Okay. I would not bother with the core for this patient if I find that she's already very tense, right? Because it's not gonna help. She's not gonna be able to do it. It's a tight, shortened muscle. You cannot strengthen a tight, shortened muscle. You have to make it flexible before you strengthen it. So I would go with that. Now, breathing, you can teach them to go on, if they're not using an Indian toilet, you can ask them to try and put a stool under their feet when they poop.
Okay.
Right? So that will relax their, what is it called? Puborectalis. And that will help them a little bit more. When they're sitting on the toilet, they shouldn't be pushing. Ask them to sit on the toilet, put their pants or whatever down all the way, so not around their knees or something. Fully relax, bare from bottom down, feet apart, stepped apart. So not like together and the knees apart. No, not feet together, knees apart. Feet apart, right? So because if you have your feet together, knees apart, your femur is facing inwards, it closes your pelvis. It doesn't open your pelvis. So feet apart, right? And ask them to do deep diaphragmatic breathing in that position. They may have a little bit more feedback because their sacrum is free when they're sitting on the toilet, and they will be able to probably engage a little bit more. Okay. That's a possibility. You can give that a try, give that deep breathing a good go, and see where and correcting that breathing pattern is extremely important. Right? And then you can teach them very simple lower extremity stretches like calf stretches and hamstring stretches and piriformis stretches, and have them breathe at the end of the stretch. Depends on how arthritic they are, right?
Yeah.
Okay. Manjula has a question.
Yeah. Go on.
Yeah, Anshul, this is regarding vaginal prolapse. So over here, I'm working as a primary MSK therapist, and I'm not a certified women's health physio. But we do get one or two patients with vaginal prolapse. So how do we manage them actually? We have like 6 sessions which will space around between 2 or 3 weeks apart. So how do we manage them in that setting? And what would be a criteria to refer them to a specialist or use pessaries and all that? Because we are not trained to do that. And we have to, sort of get someone else's help, like a nurse or a midwife who's trained in that. But we do get 1 or 2 referrals. So yeah, sorry. My question is, with only history collection and examination, not internal examination, how can we assess whether that patient will be a suitable patient for a non-internal therapist or a non-specialized therapist like me?
Yeah. So there is a subjective questionnaire regarding pelvic organ prolapse on how much discomfort. I will make sure to send you that questionnaire.
Okay.
I'm going to send you that questionnaire to your email or your WhatsApp. That will
Okay.
tell you the severity of symptoms, because oftentimes people can have more prolapse but less symptoms. It can have less prolapse and more symptoms. So if, as an MSK therapist in outpatient setting, as long as the symptoms aren't too severe, you can work on, and you do not know what exactly is driving their prolapse. You can start with the musculoskeletal assessment of their flexibility and their core strength and their movement strategies, and see what's driving, what's causing the prolapse, right? If you find that they don't have pain, they only have prolapse, there's a chance that strengthening the core and strengthening their pelvic floor may work.
Okay.
But if they don't have pain, but they are using a wrong strategy, breath holding or increased intra-abdominal strategy for moving, then you got to correct that first before you strengthen their core. If they have pain, right? If they have excessive pain, and you can ask them, does the pelvic organ come out of your vagina or does it stay in, right? So that itself, just by asking them, and then they will say, you know, in the morning it's okay, but by the time in the evening I'm done with my day, I feel more pressure. Right? So that that particular person will have more of a dynamic kind of prolapse, which settles as when they lie down and they sleep, it settles, and as the day goes by, the gravity causes the prolapse to worsen and keep coming down. You can tell these patients to have a break in the daytime where they keep their foot up, right? That will help them against gravity. One strategy that really helps is making their pelvis more flexible. That helps them to accommodate their pelvic organs even when there is an increased pressure. You can have them do that. So that may be a good way of finding out. If you get a referral and they can tell you what grade is the prolapse, you can do even better. So you know, grade 1, grade 2, grade 3. If it is exiting your vestibule, if it's exiting your introitus, then going for pessary will be a better idea, right? But as I said, and a lot of people who have pressure and pain with prolapse, they don't do very well with pessary, because the pessary causes more pinching on their tight trigger points in their pelvis. Right? It's the same thing as some people who can't use tampons, because it causes, they already are so congested, anything in there will hurt. So a lot of people have failed pessaries just because they're like, it hurts so much. So I hope you kind of got a little bit of
Yes,
answer.
actually.
Okay.
Yeah, yes, I did. Yeah. Thank you.
Okay. So
yeah, okay. I just have a thing like how much more of content do we have? Can we take questions?
We have two more parts to go very, very quickly. Just give me 5 minutes, or not even 5. Okay. So here we have a list of interventions, right? Sorry. Go ahead, Margaret, please.
Take questions at the end of the session.
Yeah, let's do that. Let's do that.
Yeah.
All these different interventions, right? We already talked about that, educating the patients about urgency. Tell them that not drinking water is not going to help. If they are really worried about nighttime peeing, tell them, okay, only sip after, like sip 2 hours before you're sleeping. Don't gulp, sip. But other than that, if you're going to stop drinking water, your urine is going to get concentrated. It's going to irritate your bladder even more, and your urgency may only get worse. So education about, do not try and clean your vulva too much. It's a self-cleaning oven. People who try and use things to make it smell good. No, you don't need that. So, using plain cotton underwears with least amount of dye, try not to use thongs, all those things. Those are all part and parcel of your education, education about do not, bear down when you're doing stretch, and education about pooping. So many people have to teach that you've got to poop better. Don't push. Put your feet on a stool. There is something called a squatty potty for people who use Western toilets, right? Indian toilets are the best. You cannot do anything better than squatting for your pelvis. That's like, you know, we are losing that. In India, we are losing that wonderful, wonderful function we had for squatting. I have my patients who are full term and they squat. I make them squat and I tell them, you've got to. And there was a question asked in one of the forums saying that a yoga instructor or a fitness instructor told my pregnant patient not to squat. Do we have any evidence behind squatting or not? And I said, see, there is a full country of people where pregnant women had no choice but to squat multiple times a day to pee and poop. That is your evidence. It does not cause any problem. Squatting is one of the safest thing you can do. And all the people on this forum or on this presentation today, if you can continue on squatting, do not lose that skill. It's a very, very wonderful skill that we have as Indians. Let us keep it. And if you don't have it, try starting it now. Okay. Then there is the cognitive functional training. It's similar to CBT. It's for people with more complex problem. You know, as I was talking to, I think Margaret was talking about somebody with autoimmune problems and multiple issues. You need to find out if they have central driving factors, if they have depression, they have anxiety, they are stressed. If that's driving their problems, then you have to address that, because just addressing their tissues is not going to be enough, right? Electrical stimulation, I use it, but not too often. When patients have otherwise everything is okay, it's just that due to surgery or due to childbirth, their pelvic floor is not strong enough. We use pelvic floor in an internal electrical stimulation to bring their muscle power from 0 to 2, and then from 2 onwards we do more exercises to improve that. Pessary, I don't fit pessary, but it's a really good resource that we have. We send them to our family physicians, or there are physiotherapists that fit pessary. There are naturopaths that fit pessary, and it's a good way of preventing prolapse and worsening of prolapse and worsening of symptoms. So that's your intervention. Now, this is something really important. Now, we use it for all our patients in our clinic if they are presenting with low back and hip pain. It's called Cozien's pelvic dysfunction screening protocol. If you have 3 yeses in this, 3 or more yeses in this list, you may have a pelvic floor disorder. Okay, I'm going to read it. You guys can read it too. Find out if you have it. Okay, you have some pelvic pain. It could be in your genitals, your perineum, your pubic area, your bladder area. If you have pain with urination, which is more than 3 on 10. If you can remember falling on your tailbone, on your low back or buttock, even in childhood. If you have urinary symptoms like accidental loss of urine, unable to completely empty your bladder, having to pee very quickly, painful urination, and what is the last one? I can't see it because it's got something on it. Difficulty starting or stopping the pee stream, right? If you have to wake up in the night more than 2 times. If you're over 60, getting up more than once is okay. But if you're younger and you're getting up once or twice in the night, that's not correct. You can improve that, right? If you feel like you have increased pelvic pressure, if you feel like your pelvic organs are slipping out, history of back pain, low pain, hip pain, tailbone pain, sciatic pain. Sciatic pain. I often see patients with sciatic pain who have pelvic floor dysfunction. Bowel problems, loss of bowel control, can't empty your bowels properly. You sit on the toilet, you only poop half. You have to strain while you're pooping, or you have pain. You cannot start your bowel movement. If there is pain with sexual activity, a lot of women just grin and bear it. It shouldn't be like that. There is definitely help available for that. If sexual activity increases the symptoms, that means after sexual activity, I have more pain in my bladder. I have more pain in my perineum. My back pain worsens. I have burning with urination. All those symptoms are increasing with sexual activity, or prolonged sitting worsens my symptoms, right? There are people who say, I can do everything, but I can't sit for too long because I feel like there's a golf ball under my bum. So those are the questions. It's called Cozien's pelvic dysfunction screening protocol. It's available freely on the internet. You can download, use it in your settings, and you will know who to guide which way, right? Okay, so that was our presentation. I hope I didn't go too fast. I hope I was able to cover as much as I can. Now you guys can shoot your questions.
Okay, thank you so much. It was really good because we don't have enough researches online or content online, or we don't have too many material to read from this for this particular topic. And like I said, the scales are all in the progress of getting standardized, and our assessment also, it's very subjective because we can't use subjective tools. Even in a clinical setup, I don't think using objective tools is very easy because the sanitizing issue. And even if it is kept sanitized, I'm sure most patients are very apprehensive given the place where we use it and stuff, chances of infection and everything. So that was quite a good session for us. I think as most of the women in here will now start introspecting or checking themselves on how good, I think we have to do that, as therapists ourselves, and keep our pelvic floor intact. That way, if it becomes a habit, it's easier to teach other women. Yeah. And there was just one question about how to stretch pelvic floor muscles.
How to stretch. Breathing. Deep breathing. There's nothing better. You start with deep breathing. You do any stretch in your body. You could do a neck stretch and deep breathe.
All right.
Right? You can do adductor stretch, piriform. So my standard go-to for my patients, if I want them to start stretching, is I give them lower extremity stretches, which is glute stretch, piriformis stretch, happy baby pose in yoga, child's pose, hamstring stretch, calf stretch, and I ask them to deep breathe with the stretch. And you know what? Not just women, men have pelvic floor disorders as well. They will not tell us. They will not tell us. They will have a lot of men with hip pain, a lot of men with coccydynia. They have pelvic floor disorders. There is a big need. And how do we assess men? We assess them internally through the anus, because that's how we access those pelvic floor muscles, because they don't have a vagina, right? So it is possible even in men. So Manjula has a question.
Manju, please go on.
Yeah, so my question is about pelvic floor dysfunction in men. How do we assess it, not being an internal therapist?
You will go with the history. You'll go with the hip flexibility, right?
Okay.
Those are the two best ways for you to find out. I have a really good male pelvic health therapist here in town, so I refer.
Okay.
Instead of, I refer. I do that because I think that and there is one more method actually, which is newer, and not everybody has the availability of it, which is a real-time ultrasound feedback. It's like a biofeedback, but you use ultrasound, and you do a trans-abdominal ultrasound and have them do the levator ani lift or deep breathing or whatever to find out how good their pelvic floor is. Is it relaxing enough? If it's tightening enough, right? Men with pain on sitting and men with tailbone pain, most common, right? Pain-wise.
Yeah.
And teaching them to breathe and stretch. External work, sometimes it can be a little bit more tricky, because when it comes to external work, even for that, you need to go very close to their butt crack, their anus, their gluteal cleft, right? Because that's from there where you can access your muscles like coccygeus.
Yeah.
Right? Really, you can palpate their tailbone and see if it is deviated. If they have right-sided pain, their coccyx is a little bit more towards right side. you can assume that the right side muscles that attach between coccyx and your pelvic bone is tightened or shortened. And you can probably release that. You can use a ultrasound head to release it. Like, you can use ultrasound, but you use it for warming up as well as doing a little bit more of that myofascial release. You can use a tool, one of those handy tools that you get for that. That can be a little bit more tricky, but it's possible. And the post prostatectomy pelvic floor disorder in men, where they have weakness and they dribble, right? They need to strengthen their pelvic floor. So you teach them, the cue is shorten your penis, or pull your testicles. That is how you tell them to do a levator and eye contraction. Cueing is really important. The words are really important. You tell them, oh, do a levator, they won't understand that, right? So you have to tell them the right cue. Okay, sorry, go ahead.
Yeah, so my next question is regarding DRA. So there is a patient with 1 year postpartum and around 3 finger breadth of DRA. She would want to go back to weight training. So even after the sessions, it was getting better, but then it still has a gap of at least 2 finger breadths. So what do we advise? She's loading it much better. She's actually becoming better. So towards the end of her sessions, I'm sure she will definitely ask me the question whether she can go back to weight training, because each session she talks about it. So just want to know like how we would be able to advise them and what are the precautions we need to take for that.
1 year post, with regards to the separation, the looks of it, it is what it is. Okay. Check out how is her linea alba firming up when she is on a task. Have her do a plank, palpate her linea alba. Okay. Have her do a single leg stance and palpate her linea alba. You can make her do single leg squat and palpate her linea alba. See if she is able to have good firmness of that tissue. If she's able to kind of load transfer through that. And if it is 1 year and if it's mostly for the looks of it, there is really no risk. As long as she's breathing properly, as long as her load bearing strategies are optimal, there is no risk as such. But she'll have to, if she's not done weight training for this long, she'll have to start from scratch.
Okay, but she used to do it before she becoming pregnant, but during the pregnancy and after this, she hasn't done it.
So it's been 2 years almost, right?
Yeah, 2 years almost, yeah.
So she'll have to probably start from scratch. So have her do a lot of horizontal tasks first, like single leg bridges, bridges with the resistant bands and so on and so forth. You can have her do planks, side planks, reverse tabletop, all those heavy load bearing tasks. Then you can move her to vertical, and from vertical, you can get her to do weights. So transit through.
Yeah. Okay, Andrea.
Okay.
Thank you. That was very useful.
Yeah.
Okay. Rupalok has a question.
Rupalok has a question. Rupalok, you can go on.
Hi, Anshul. Nice presentation.
Thank you.
Few questions which I had. One is this DRA which you are talking about. Don't you think taping also helps when you do with the DRA?
Depends on what you're taping for, Rupalok. Like, as I said, we are not and that much focused on reducing the gap anymore, right? We are focused on better load transmission through your linea alba. If your taping is to improve that part of loading through your linea alba, of course you can tape it. But if your taping is to reduce the gap, it's really you're distorting your by reducing the gap, you're distorting the linea alba. It won't be able to load bear and it will be futile. So taping, if you're going crisscross to approximate your rectus, it's not going to be of great use. But if you're taping to improve the connection between your, the bottom of your sternum, what is it? Zippy sternum and your pubic symphysis, maybe, but I don't tape for DRA. So.
Okay. Another thing which you're talking about is like you're talking about this entire core thing as a whole piston sort of a system, right? So you spoke mostly about your transverse abdominis, you spoke about your pelvic floor muscles, but the diaphragm does play a role, right? So if you
Oh,
have an inhibited,
oh yes.
hello?
Yeah, yeah,
Yeah,
yeah.
yeah. So if you have any issues with your diaphragm, so do you think your pelvic floor gets affected, and how does it get affected, and what can you do to release those diaphragm?
Okay. So with regards to diaphragm, right?
Yeah.
It's actually really important. And I'm going to send you a link from a journal that talks all about breathing and core. Um, 1 second, I'll write it down. Okay. Diaphragm excursion, making sure it goes from its dome to flat, you know,
Yeah.
plays a huge role. In fact, you know that diaphragm is not one but two, hemidiaphragms.
Yeah. Yeah. Yeah.
So you finding out um, if it's not coming down all the way, and if it is
Yeah.
stuck, releasing it manually. There are therapists that do diaphragmatic release. I'm sure
Yes.
that there is a free content on Diane Lee's website for that as well, for diaphragmatic release. Also, if you have your intercostals too tight, that will
Yeah.
also hinder your diaphragm from going
True.
down. So you're gonna have to probably
It
manually release those as well.
it mostly happens when you have rib fractures. So
Here
that's,
you go. Yeah, here
yeah.
you go. So what you're doing right now is you're putting the blocks together. This is what a physio should do, is to kind of put your rib fracture, poor breathing strategy, increase use of accessory muscles, decrease use of diaphragm, brings
Yeah.
your core to become weak, and so on and so forth.
Okay. Thanks, Anshul. I would look forward to that link which you're
Yeah, I
supposed
have
to send.
written it down. I will be able to send that to you.
Thank you, Anshul. Nice presentation.
Thank you.
Okay. So I think that is the end of questions. Actually, if we go deep into the management strategies, we have a lot of other questions that would really pop up. And like you said,
You
we
are
might
free
have,
to ask any question. There's always some answer that can be given. I mean,
yeah. So um, uh, with my thing, I think I am done with my questions. I see uh, Anupriya says thank you. And I
thank you,
see
Anupriya.
one, yeah, almost what I had on mind has been covered. And it's quite a nice session. Thank you so much, Anshul, for taking all your time and, doing it. It was really informative. And we look forward to interacting more with you. I think that will be more of, when we have any cases or when we have any doubts, directly asking you, I think would help us much better. Yeah. And this breathing exercise thing, and that being a strategy for the pelvic rehabilitation, is a very nice thing. So thank you so much. Over to Lenny.
Oh, thank you, Margaret. Anshul, if you wouldn't mind sharing your email ID to the participants, it will be of great help so that they can contact you directly.
I'm going to put it in the chat.
Okay, so those of you who
Yeah.
would like to contact Anshul, maybe if you give your consent, they can contact you directly for any questions and clarifications, and I'm sure you'll be happy to take it.
Okay.
Okay, there you
That's
go.
my email address. Yeah.
Okay.
Okay.
Anshul, thank you so much for taking time off on Saturday morning to take the session on women's health. I think it's greatly appreciated for taking your time off, and thank you for Magesh also to staying back and helping out for the presentation. And thank you, Margaret, for your wonderful moderation. And thank you all participants for taking your time and sharing in the OPTAA webinar series. And thank you so much for your time. And we look forward for the next month's session also. So we'll keep you posted on it. If you have any friends or any therapists who may be interested in attending, please feel free to call them as well so that they'll also be benefit in the learning process.